The C-14401 trial that led to the approval of lifileucel for metastatic melanoma focused on and only included patients who had treated asymptomatic, stable brain metastases. So patients that had had prior brain mets were required to have those definitively treated with surgery and or radiation, as well as a small number of patients who had had prior stability, following systemic therapy, and then demonstrate a period of stability after that treatment. And unfortunately, many of our patients just won't be able to get that period of stability in the brain. And so those of us using lifileucel in the clinic are really faced with the challenge of saying, I'm sorry, but we don't know about the safety of this new exciting treatment for you in the clinic. And that was really what led us to design this pilot trial. When we sort of put that against the background of, there had been patients treated over the 38 years at the National Cancer Institute that had received TIL therapy, and including those who had had active brain mets, we knew that there was the potential for efficacy in the brain. But some prior case reports and small case series had raised some concerns about safety. So in that NCI series of 18 patients, there was one patient who had had a large symptomatic intracranial hemorrhage that did require craniotomy and had neurologic complications for that patient. And a case that was reported at AACR several years ago, in which the patients had seizures during the IL-2 treatment, which is a known complication of IL-2. And so we wanted to try to bring this treatment to our patients, but balance that with these safety signals. So we designed a pilot trial of 10 patients to look at the feasibility of treating patients with lifileucel with a modified treatment regimen. And the modifications included keeping the platelet threshold or platelet transfusion threshold above 50,000 platelets. And that was important at the National Cancer Institute. That patient that had had the intracranial hemorrhage, that was at 26,000. And so we set that platelet threshold at 50. Additionally, all patients were put on seizure prophylaxis from the time lymphodepletion started through the end of their course at day 30. And what we found in the initial treatment was that it was very hard with the standard lymphodepletion regimen to even keep the platelets above 50, even with ongoing transfusions. And so we actually modified the dose of the lymphodepletion chemotherapy as well to try to decrease the degree of thrombocytopenia as well as the duration of the thrombocytopenia. And so we used a dose of cyclophosphamide, 750 milligrams per meter squared for 3 doses, and fludarabine 30 milligrams per meter squared times 4 doses. And with that, plus the other modifications, we were able to get patients through this protocol.